an enormous pleasure to be able to introduce Herb Schultz. We're thrilled to have him here. He was appointed by President Barack Obama in 2010 as the Regional Director of the U.S. Department of Health and Human Services, Region 9. He has an extraordinary background before coming to this position, and I could spend a long time on that, but I know that all of you, like me, are very eager to hear from him about what is in the news, not only every day, but it seems like every hour, about what's going on with the Affordable Care Act. He is in the midst for us, for this region, Region 9, where we all are, of really leading the efforts to get the largest transformation in healthcare and in health services, not only in this generation, but in several generations in the United States off the ground. So he's going to come and talk to us right now about federal, state, and local partnerships.
Good afternoon. It's great to be back. Can you hear me? Yeah. I do musical theater. I won't sing, but I usually have a mic attached to here. And at least one other person said I did musical theater too, so we'll do that. But enjoy your lunch. And it's really great to be back here. I have to say, I've probably in this job spoken well over probably 1,000 to 1,200 speeches and events and things over the last 3.5 years. Some of you I know, and I don't usually get nervous when I do speeches. This one, because I feel like I'm talking to a crowd that knows everything there is to know about the Affordable Care Act and everything else, so be kind to me, please. But I want to thank the Dean, and I want to thank her for her new leadership. I can't believe it's been almost a year, because it was splashed over all of the news, not just here, but across California and the country, and we're very lucky to have her here in not only the region, but in like California and in Region 9. So thank you for your leadership, and Erin, thank you for putting everything together. So let's give them a big round of applause. What I'm going to try and do today is maybe do only about 20 minutes of, if that, sort of speechifying, because I know you've got a lot on your mind, right? This issue? Oh, as you're eating, you can just nod. Okay. But I think you probably do. I had an opportunity to be with some wonderful students this weekend, and as they were sort of, the host was pulling me aside and saying, you're going to miss your plane. I said, I don't care, because I love being at universities, and not just because I'm standing at UCLA, but you really are a jewel in the crown. And it's a privilege not only to work for the president and for Secretary Kathleen Sebelius, but to work on your behalf. And as I said to Jerry Kaminsky with the great UCLA Center for Health Policy Research, a lot of what I do is trying to make sure that the Secretary, the President, the White House very directly knows the work that is going on, knowing the organizations, the individuals, the leaders. They certainly know UCLA. But within the administration, it's very clear that California is a very, very big piece of this historic expansion of healthcare coverage. And I will tell you that for those of you that have been involved in many of the studies that you're doing and stuff, they have been seen within the White House and within HHS and others, because I'm very proudly talk about all the great things that you're doing. So I know many of you have been involved in that. So here we go. I'm going to do, as I said, about 20 minutes. My job is not politics. My job is the intersection of policy and sort of what happens in the world of, if you will, policy making and implementation. I like to say I look great in vertical stripes, but not in horizontal. So you should feel free to ask me anything you want to do, but I won't be talking about 2012 or 2008 in the way that some of you may want me to. So this is obviously health reform, the ACA, Obamacare, 3.5 years ago. Now, in some ways, for me, it feels like it was 20 years ago, and in some ways, it feels like it was, as you said, an hour ago, because Jay Carney made some remarks about the cancellation issue, and so it is an ongoing dialogue every day. The reason that I wanted to start with this context is because a lot of folks are still sort of, if you will, waking up to becoming familiar that we are very, very close to this historic expansion of coverage, and we're in this open enrollment period. But you know far better than probably most people that we've been implementing the Affordable Care Act for the last 3.5 years, since in fact the day that it passed. And my appointment was a couple weeks after that, so I've been able to sort of be there from the very beginning in terms of how do you take this 2,700-page law and how do you put it into practice. And we'll talk a little bit about those partnerships and the lessons learned, because it really has been the driving point, especially in my region, about how this law is getting implemented and how it has been implemented. So this is the three-legged stool. We're in academia, so I'll use the three-legged stool analogy: improving quality and lowering cost, consumer protections, and I'll save the sort of current thing that we're doing for last, although we'll talk probably most about this. And the exciting thing is when you look at improving quality and lowering cost, UCLA in many, many forms, including this Fielding School of Public Health and the medical center, et cetera, your center, many of the pieces of this have obviously not only benefited from ACA grants and awards, we're benefiting because there have been real changes already in 3.5 years to our healthcare delivery system, which UCLA and others, through policy research, through research being translated into practice, through grant awards, including the one that Tony Yancey, may she rest in peace, did with obesity, and the program that you all have done here. So the reason I want to put up just a couple of sort of where we are before we sort of drive into what it is because we really have begun in this country to reduce healthcare costs. There's much more that needs to be done. But if you look at Medicare and Medicaid and increases in the cost of healthcare over the last 50 years, we're at the lowest level we've been in 50 years. And a lot of that has to do with significant programs and initiatives that come through the ACA. It's not just because we're having a slowly evolving, better economy, but it really does have to do with a lot of different things. And we could go into all of these in the Q&As, but I think there's been real justified, if you will, reductions in cost and significant increases in quality. And many, as I said, of some of the initiatives, there have been LA County, California, leaders in the fight, UCLA, in sort of doing this. Now, I also want to put up the consumer protection piece because I've got some California stuff in there, but there are a lot of people, we're talking about now, obviously, those people who are insured. And these are the sorts of things that are happening across the country, but are happening here in California, which is a really important piece when you look at what we're doing with the expansion of healthcare coverage. Because in going out across Region 9 is California, Arizona, Nevada, Hawaii, the Pacific Territories, so Guam, American Samoa, and the Commonwealth of the Northern Mariana Islands, Saipan, and it's also 3 island nations, Micronesia, Palau, and the Marshall Islands. So we're 50 million people. We're hundreds of thousands and millions of families and institutions and organizations and philanthropies and providers and all of those sorts of things. But we're talking about moving away from a system where, you know, I use this line and somebody once challenged me and said, well, what do you know about it? And I'll give you the line. And what the line was is no one should ever have to choose between the cost of a medical procedure, tuition, rent, or prescription drugs. That's what the ACA is doing, and I could give you probably hundreds of examples from across my region of families, young adults, seniors, many who are financially ruined, many of them who are no longer with us. But also, I've been a person living with HIV for 22 years. And so when I talk about the incidence of chronic disease and public health, or what we have to do on coverage expansion, it comes from the perspective of working across this country, but the last 3.5 years working across this vast region, and not only sort of hearing and listening, but trying to understand and take that information back into a public policy process so that in the words of your core elements, you can research it, you can educate, and you can put it into public service. And so it works all together. So that's why I wanted to sort of start and just sort of frame your mind that we're not just switching on a light bulb and saying ACA starts on January 1. But I understand that for much of our country, that's what it feels like, because that's what change is. Now, I was only 3 when Medicare and Medicaid came in, so I can't liken it to that. And I won't even start that many of you were not there, weren't there for a long time, okay? And I want to ask those who were working at that year, okay? So we'll talk quite a bit about this coverage expansion because this is really where we are. And what you've heard about here in California, Covered California, or what you've heard about healthcare.gov and its Spanish language counterpart, cuidadodesalud.gov, okay? There are marketplaces in all 50 states, and we still every day are hearing people think that there's only marketplaces in 12 or 14 states, whoever's going to be doing their state-based marketplaces. Medicaid expansion, and we'll talk about that. And we're very fortunate to be here in California, which obviously has a state-based marketplace called Covered California, and the Medicaid expansion. So let's get into sort of what I wanted to talk about in terms of how partnerships drive the implementation, and partnerships at any different level and the lessons learned from that. And I'd be remiss if I didn't say, you know, UCLA, prime partner. Fielding School of Public Health, prime partner. Center for Health Policy Research, prime partner. Medical School, Anderson School. A lot of different things that we've done together to do that. And I'm very excited about a new dean and a whole new approach and working with all of you. But I wanted to put up, so here's sort of what my office is and what we're supposed to do. You know, I had to get comfortable, and you'll see in the lessons learned, with the fact that I came into this job having been senior advisor to Arnold Schwarzenegger, labor secretary to Gray Davis, and a various assorted other things. I used to call myself deputy dog. But I was fortunate, I got to move beyond deputy dog and become a decision maker. You know, when you're labor secretary, you get to make decisions. Not on your own, you got to talk to the, you know, governor's office, got to talk to the governor, you know, and Arnold and Gray can tell you that. But you're a decision maker. And the thing that I had to get comfortable with in terms of this job is that this is an enormous platform. It's an enormous platform to be able to give 50 million people an opportunity not just to educate them or help troubleshoot with various federal agencies, and we'll talk about some of this, but the work that we've done together, and especially I'll use the Center for Health Policy Research for a second, is inviting you, and I am inviting you, on an ongoing path to help us continue to make sure that the implementation policy, because I always say a law today is a regulation tomorrow, is guidance the next day, is questions and answers the next day, is another statute the next day. And whether you're doing research, or whether you're doing policy research and putting that, or whether you're, you know, teaching other folks, or you're pressing then into some form of service, whether it's public service or community service, whatever it happens to be, you all can make a difference. And I can't get out there and say, all right, well, we worked with these constituents, and the Bridge to Healthcare Reform waiver in California, the 1115, shifted this provision because of that. But my job is to make sure that for every one of you, as individuals, in your community, in the community, in this school, that we know how, what this law does in sort of broad framework, how it impacts you at the local level. Because it's not about the federal implementation of the Affordable Care Act. It is about the state, local, and in my region, tribal and territorial implementation. I have 160 tribal nations, federally recognized tribal nations, and those territories, and those countries to do that. So you're not only playing a valuable role, I think, as students or as faculty or as staff, but I'm inviting you into this continuing process. And that's been a huge rewarding part about it. So I put up sort of the list so that you could just see, well, what do I mean by partnerships? And the partnerships go from elected officials sort of all through, and these are the, big terms. You could, when I look at providers, and I'm not just thinking physicians and NPs and physicians assistants, and I'm going through social workers, and I'm going through assisted living facilities, and I'm going through a whole, if you want to talk about sort of who these providers are. But these are, in sort of large part, a significant amount of the partners that we have and the partnerships that we develop and the partnerships that we have utilized to be able to, if you will, implement this law at the local level. And LA County, you can look at LA County and in any number of ways probably find people all through here, maybe you're parts of these organizations, or you've started organizations, or you're working in these organizations, and this is by means not only an exhaustive list. So I want to give you some lessons learned to really sort of kick off the discussion, and we can talk about anything, but these are ones that sort of came out to me. This sort of challenged me because I was like, yeah, I usually getting out there and going, okay, let's talk about leg 1, let's talk about 2, let's talk about 3, and then have a, candid conversation. But a lot of what's out there. And so what I want to do is sort of tell you sort of my own sort of lessons learned on these things as you're doing them. Now, you cannot separate policy from politics or politics from policy. As I said, vertical stripes, not horizontal stripes. But what I mean by that, and you're seeing examples of that every day, even this morning as we were talking about, I'm talking with the dean, and that is that when you go back in history, and you don't have to go back in history very far. I don't want to know who of you were not born before 1989, okay? But I'll use 1989 as the example. The first week in my job, when I became a healthcare lobbyist for the then fledgling HMO industry, promise of prevention, 2 years before I became positive, I was active in the in those days, the LGBT community, and we were fighting that thing called HIV. Little did I know it was percolating in me. But that's what we were doing. And I didn't know that much about healthcare. I had, some of you will know this name, I had Dr. Judy Fader for one class at Georgetown University Public Policy Program. And I wanted to go into health, or I wanted to go into health policy. And Judy, to this day, just turned me on, and it was health policy. So my goal had been, I want to be a lobbyist. I worked on Capitol Hill, want to be a lobbyist, before you have all these legislative degrees now. And I got this job. I got this job with a company called FHP, which is part of the United Empire now. And I was their second Washington lobbyist. But how much did I really know about healthcare? Especially because I had had one class, Judy's class, and the last class, alternative delivery systems, that was HMOs. Okay, but it was a public health course. The first week I was on my job, my boss at the time, who went on to be a MedPAC and is still a big consultant in Medicare, came into my office and said, here, I know we're giving you all of this reading so that you can come up to speed. Puts on my desk, 1989, a new Heritage Foundation report called The Individual Mandate for Coverage. Sound a little familiar? So how many of you remember Speaker Newt Gingrich? Majority Leader Dr. Bill Frist? Bob Dole, Majority Leader? Go back to YouTube and put in individual mandate, but put in individual mandate 1996, or put in individual mandate 1998, okay? You will see YouTube clips of the then majority in Congress promoting what basically is the Affordable Care Act today. Because if you take 1995 to 2007 out of the equation and you go through that 2008 cycle, where Hillary Clinton and John Edwards were also individual requirement supporters. 2006 to 2008, California. Anyone aware of California's 2006 to 2008 debate on health care reform? Okay. It went something like this. Arnold Schwarzenegger, governor, Democratic legislature. Democratic legislature sends down employer mandate bill. Arnold Schwarzenegger vetoes it. The Service Employees International Union supports an individual requirement. Speaker Fabian Nunez, other party, does it, wins in the assembly. Every member of the Democratic Party with the governor. And then we lost it in the Senate. When the president came into office in 2009, there was not a debate. There really was, other than, you know, people wanting to have single payer, but it wasn't the biggest. California shifted what had been a Republican issue to a Democratic supported issue. And we went into the Affordable Care Act. So I will leave it to you to whether you think politics, you can separate it from policy, but you see I have little hair. I'm the only one in my family, thanks to my mother telling me, that's ever lost their hair. I consider it the pulling out of every time I say that, well, why was it constitutional then, but it's not constitutional today? There is not a lot of difference between the individual requirement that was being promoted in 1995 to 2007, or what was promoted in Massachusetts through then Governor Mitt Romney. But the real model actually beyond Massachusetts was a lot of the things, and UCLA had a very big impact on that 2006 to 2008 debate. So I could give you lots of examples, and I hope we can talk about those examples. But I find it impossible to separate politics and policy, because many of the issues that you're seeing play out with the problems with the website, with the cancellations of individual plans, I'm not saying whether or not that's right or what the policy is going to be. That's up to the president and the secretary and Congress. But there is a real distinction between a policy level debate that we're trying to have and a political debate that we're in the midst of. And that is, to this very morning, very, very true. Now, relationships with elected officials are multifaceted. How many of you have worked for an elected official? Okay. How many of you are elected officials? Could be in your community, in a neighborhood commission or stuff like that. How many of you have spent time with an elected official? Okay. How many of you like spending time with an elected official? I do. I really do. And the reason that I put this one up is multifaceted, because there's two examples. Constituent casework. Now this one may seem intuitive to you, but if I write on a board the names of members of Congress who we have phenomenal relationships with on a constituent casework side on all of these issues coming up with the ACA, and then put a list of those members that don't support the ACA, guess what you'll find? They're the same people. And you could say, well, it's because what constituents want is one thing, the politics and the policy is another thing. Hopefully we're not burning up. We'll see what that is. Yeah, someone set the fire alarm? Okay, you would hope that it would ring in here too, right? Anyway, so relationships with, so what I'm saying is, I work with a lot of elected officials, mayors, state legislators, and especially Congress people that are anti-ACA, but yet they are expending a lot of time through their staffs working those constituents through the Affordable Care Act. But the flip side of that is the non-ACA issues, because as much as health reform now is taking up maybe 90% of my job, elected officials are not one-sided. And so they may be out, every talking point may be anti-ACA, but there's a lot of other issues going on. Now this one I think you're going to like because I learned this long ago in therapy. And my therapist took my partner's side, so I wasn't exactly happy when I learned it. But I've honed it in this job, and I'll tell you why. You cannot tell somebody how to feel. What do I mean by that? Now, I'm going to exempt, not just because I'm at UCLA, I'm going to exempt UCLA from this example. Public health professionals. I have been through my region for 3.5 years. I could tell you the number of times public health professionals say to me, why are you talking to me about healthcare coverage? Why aren't you talking to me about epidemiology? Why aren't you talking to me about vectoring? Why aren't you talking with me about the fight of this chronic health condition or this non-communicable disease? What's going on? Well, the Affordable Care Act has, it's not just free out-of-pocket copays. It has a benefit called prevention, wellness, and chronic disease management. It has a benefit that we finalized last Friday called substance use and mental health parity, at parity with physical and medical and surgical benefits. It's huge. It's the benefit side. And I've had a lot of public health people say to me, what are the benefits? What do I care about the benefits? I want to talk about vectoring. So that's not UCLA, and I'll tell you why. Because of the great work that you do in policy research. But I could tell you, I still go to public health events all through my region. And I have to get through a real, with that audience, which is important, I have to go through, let me talk to you about Medicaid expansion. Let me talk to you about what a marketplace is. Let me talk to you about these essential health benefits so that now finally these diseases, chronic, communicable, non-communicable, that we're trying to fight, that now people are actually going to have coverage and that you can actually move them along the spectrum of preventing them, or at least doing secondary prevention, because you have those benefits. So I'm exempting UCLA, but I think it's a good topic to be talking with public health professionals about, because I still talk with more people in the public health community about the national prevention strategy and all of these others. But the benefit side of the national prevention strategy is as important as that fight against chronic disease. Now, how many of you consider yourselves health insurance geeks? Yeah, I knew you were going to say that, Sherry. Okay. Agents and brokers. I'm going to say agents because in some ways they're getting overlooked in this debate, but you know, we're trying to provide comprehensive coverage to more than 40 million people that don't have it. And so in addition to a lot of other types of ways through websites and through, which we'll talk about in a minute, and through communities educating communities and assisters, we have agents and brokers that help especially small businesses into coverage. And this is a huge number of small businesses. But when we started this, agents and brokers and consumer advocates don't exactly sometimes get along. And agents and brokers, no matter how many times I said, in this administration, you have a strong and continuing and ongoing role. We understand that you educate the community and the role that you play in helping people get insured. Some still don't believe it, even though the regulations are there. And so it's very hard to tell someone how to feel, and I try not to do that. Now, know your role, coordination and collaboration versus leading the charge. Now, you can already tell I'm not really a shrinking violet. I like to talk publicly. I have this music theater background, right? Well, how many of you are familiar with Arizona? One way or another. Read anything about Arizona? Know anything? Okay. Well, Arizona just went through a 7-month debate on whether, in their terms, to restore Medicaid, because they actually allowed childless adults under 100% of the federal poverty level for several years through 2 initiatives, not through laws passed by the legislature and signed by the governor, through 2 initiatives. But it was put on hold because of budgetary problems. So the governor, not known to be the person that maybe would expand Medicaid made a decision based on all the facts and, made a decision that she wanted to expand or restore Medicaid in Arizona. Well, you can imagine most of the folks that support her did not support that approach. And that the people that traditionally didn't support her on health and human services issues, the Coalition for Expansion, were supporting her. And so me, who's used to flying around, doing lots of events, talking with lots of people, guess who didn't go to Arizona for 7 months? And it was a very, very valuable lesson. I went in quietly once to meet with the mayor of Phoenix, and I went for my 3-day tribal consultation. But in a political debate, what were the opponents saying? Obamacare, Obamacare, it's Obamacare coming into the state. And so my tendency to want to be there, to help, to that, we talked with people on the phone, we had conference calls and things to be able to assist them. But it was a real life example of, for me, sit on your hands. Because the last thing you want to do is go and have that. We lost that because Obamacare was represented there. And this is our President of the United States who has made history. But it was the practical dynamics of, let the local organizations and leaders make the decision that's best for them. And that's how we've treated this around the country. I happen to believe that more states will sign on to Medicaid expansion. More states will. One thing that's getting lost in this debate is a lot of people will say, well, there's 25 federally facilitated marketplaces. Well, yes, but there's also a process to transition over 1 year. And I happen to think ultimately we will have far more states in Medicaid expansion, and we'll have far more states who will be running their own marketplaces once you get past this initial period. The last two, translation of technical information. It's all about communities educating communities. That's part of the last one, but it's also, and it's I think where many of the centers and many of the programs that you have, all that work you're doing to translate research into policy, into helping people advocate what that policy is, it really happens. Because we can't expect people who are running community-based organizations and helping people live their lives and go to church and all of that to understand thousands of pages of federal regulation. And so a lot of the work that I've seen you do, you really help people translate into practice. And so for the first time in my life, I have helped people move an agenda forward by really trying to say, okay, no, this is really what this issue is all about. Because you can't expect someone, I always say to people, we have a listserv, but I'm not going to send you a 300-page regulation and say, what do you think about this? Because they're just going to shove it right back. So that's an important thing. Then connectivity and troubleshooting. Do not assume that everybody knows the basics of government or the ACA. I think I went into this naively 3.5 years ago and I thought, you know what? We will educate people year 1, we'll educate people year 2, we'll educate people year 3, they'll be ready to sign up year 4. And it doesn't work that way. Look at when people tune into sort of the elections process. They tune in September and October. When are they tuning into the enrollment? In September and in October. And that's okay to do that. But I've had more than enough people say to me, well, do you feel like you wasted your first 3 years? Absolutely not, because what I think we accomplished in the lesson learned was the leadership, the organizations, those that are really active in the process, who now are really the community members, educating community members. So as I sort of close and frame this, as I framed sort of the early, is that It is all about local implementation, and we cannot lose sight that this is a reality. This is not going away. We are implementing the Affordable Care Act despite every day issue after issue being raised. And I'm not going to sugarcoat healthcare.gov and the issues around the website. 24/7 working through those. And I think that as we come up from that and communities continue to educate communities, that we're going to see a very, very successful implementation of the law. But what's gotten lost in translation is that we're going into the 6th week of a 6-month open enrollment, that in Massachusetts in the first month, 123 people, 0.3% signed up. We've always known that it was going to take a ramp up. Save the issues with the website, which are serious and which are unacceptable, and to which you heard significant apologies about that. But what I think our job is, especially those of you in public health, is I'm not going to tell you how to feel, but I am going to implore you to move with your heart to say, this is going to be what is facing us. There will be hundreds of thousands of people next year. Maybe, we think there'll be millions who will be having that health care coverage. And so the work that you do is extraordinarily important. And so I'm interested in learning from you through this next half hour of Q&A, what's on your mind about this, whether it's you disagree with any of this or anything else that's sort of on your mind about the implementation of the Affordable Care Act. We're confident that November 30th, the website issues are going to be addressed and the vast majority of consumers will have a smooth experience. You're not seeing that every day, and we're being transparent about how things are sort of moving every day. And I understand that every academic institution is not UCLA and every state is not California and does have covered California, so I care about the whole picture. But I want to know what's on your mind, because some of these lessons to me have been that if we've not had academia, if we've not had providers, if we've not had small business people, if we've not had who frankly have pushed against the grain, because if you ask the majority of small business people today, under 50 full-time employees, are you mandated under the Affordable Care Act to provide health insurance? What do you think they'd say? Yes. And are you subject to a fine? Okay. Not true. Not true. I mean, I can dismiss the ones like I did the other day where somebody said, I heard that everybody's getting a chip planted in them. I'm serious. I'm serious. But there are these other pieces. And so in my head, my dream is waking up and getting on, the rental car bus, which I do so often these days, and hearing a mother in Spanish talking to her daughter about how they're putting her on her policy. Or I am, walking through the grocery store and I'm hearing, somebody talk on her cell phone and say, yeah, I just actually went to that Covered California website and I got coverage and it's less. That's when it becomes a fabric, but it's not going to become the fabric until all of us continue to educate one another. And you're in the perfect place to not only be studying and researching, but you put it into practice. And that's why I think UCLA, Fielding School, great place to be. So let's open it up. And I am putting up, that's my cell and my email, and is the easiest way to reach me, and we can talk about that. So let's see what's on your mind.
Can you comment on whether we're dealing with an ongoing system of monitoring and evaluation for the whole act? I
think the answer to that is, did everybody hear the question? question was, are we dealing with sort of the monitoring and the evaluation of that? I think the answer to that is yes, in many different ways. I think it's being built through the department and CMS level on all of that and the metrics that are applied to that. But we've also had a lot of good partners, including here, who have been talking with us about the projects that they're having, sort of pitching to philanthropy, if you will. So I think the answer is yes. I don't think we're at a point to talk about what actually it will be, but it will be very transparent. And I think internally, but I think externally, there'll be a lot of research and studies done. All right. Jerry? And then
Herb, first I'd like to thank you for your really kind comments on the center's work, and I can say that over the last 2 years, the work that we've been doing for Covered California and for the state on ACA implementation is the most important work that I feel that I've done in my career, and I know that my colleagues are absolutely thrilled that we're able at this point in time to be able to contribute the kind of good information that's needed by the state. I actually have a two-part question. The first part is, before this talk, I was on the website looking at news items today regarding ACA. Wall Street Journal is reporting that enrollment is disappointingly low, but this is the specific figure that I'm concerned about. They're reporting that only 400,000 people have been able to enroll in Medicaid nationwide. And as you know, in California, we have the low-income health program that's being run under 1115 waiver program. This is basically, most people probably don't know about this program, but it's a pre-enrollment program for ACA. Everybody who's in this program, and there are about 525,000 Californians today, are going to be eligible, the vast majority are going to be eligible for Medicaid on January 1st. So I wonder if you know why those figures aren't being sort of captured, because California right there alone has enrolled more people in Medi-Cal than apparently the rest of the nation as a whole.
Right.
The second part of my question is with regard to the website and the delays. You know that Commissioner Dave Jones has already said now to insurers in the state to extend the policies that have been canceled for an additional 3 months. I'm wondering if you're hearing any talk at the national level. If the website's not going to be fixed until the end of the month, and people really will only have a 2-week window to enroll for insurance that would be effective January 1st, is there any discussion at the national level about doing something similar and allowing, maybe negotiating with private insurers to extend policies for a 3-month period, one time only, because of the delays in this website getting up and running?
Two very good questions. So let me go back to the first one. The Wall Street Journal is the Wall Street Journal. We've said, Secretary said it in testimony last week, that that we expect the first month enrollment numbers to be very low. We've always said that. But those are the Wall Street Journal's numbers, and so I can't confirm anything that we've done. She has indicated that we will be putting out numbers this week, and that will happen, and we will be transparent about that. But we've always known, when you look at the Massachusetts example and you look at other examples, that the first month is not going to be an indicator of where we are after the end of a 6-month open enrollment period. The average open enrollment period, anyone want to guess what the average open enrollment period is? 2 to 4 weeks. Okay, this is 6 months. It's the same that we did with Part D on that. Number two, I think last week and something this morning, I mean, the Secretary has said and the President has said that we are looking at, and he has asked the team to look at, and the Secretary's leading this up, options to be able to, if people want to keep their health care plans, that they would be able to do so. That might be a change in the law, could be other ways, but nothing has been settled on. The President's spokesman said this morning, reiterated, that the President did say that we're looking at different options for being able to do that. So I can't tell you sort of what it's going to be or sort of what the timeline is. I haven't heard people personally yet talking about what I'll call the Dave Jones approach, because he's just done it. And I know I got a heads up this morning that it's probably why you're saying the second one, because he is doing a second one today. So, you know, I certainly have made my organizations knowledgeable about what he has done to be able to ensure that they know where California is. So my assumption is people know that is happening out here. Maybe that's being talked about as an option. I don't know. I saw it right there.
Hi.
Hi.
I was wondering if you could talk a little bit about those populations that might not obtain coverage. So I'm thinking like undocumented immigrants, but also like young adults who might opt to take the penalty, pay the penalty
Right.
instead of enrolling. Sort of what have been some of the policy discussions in your office or in HHS as a whole? And also I'm sort of thinking like 5, 10 years down the line, I'm assuming things are going to be going really smoothly. It's going to be a very popular program, and there's going to be a much smaller pool of uninsured people. Kind of what might the policy debates around health insurance look like kind of down the road?
Yeah, no, it's a great question. A couple different things. One is, as you stated, in terms of the marketplaces and the Medicaid expansion, undocumented individuals cannot go into them. In the ACA, there is an $11 billion expansion of the federally qualified health center system. Health centers, like hospital emergency rooms with EMTALA, have to take all comers regardless of documentation, regardless of ability to pay. And there is and are significant new programs around the creation of medical homes into community clinics. All of that being said, you know, this is not an issue that's going to be debated nationally within healthcare. It's going to be debated within immigration reform, and I think the president's been extraordinarily clear on the priority of trying to pass comprehensive immigration reform, and that's where it's going to be. LA County, and to some extent California, is having a discussion because this great program, the low-income health program, which I've worked a lot on both when I was in the governor's office and in this job, there is a, which in LA County language, a program called for the residually uninsured that is paid for a different way than the federal match for those who are documented. I'm continuing to be at a lot of things where this discussion, I think, is reaching a zenith. So will LA County, that's up to the county board, but I think the discussion, at least within California and specifically LA County, is getting there. But I think the broader federal discussion is immigration reform, you know, because that's, I don't have a crystal ball, and that's up to Congress to do that. So other thoughts? Yes, ma'am.
I don't think I can say exactly what the reason was behind this, but the hospitals are losing funding now in many states, and this was a planned reduction in some funding for treating low-income populations. And in those states where they haven't expanded Medicaid, that's leaving that population not only without the Medicaid, but where they used to go to the hospitals maybe for emergency services or something without the ability to get care there. What will happen to those?
Well, a couple of different things. You're talking about disproportionate share in hospitals that have a disproportionate share of Medicare and Medicaid patients and sort of funding. And there are reductions commensurate with people coming into coverage. But that's been delayed for a year. I don't, policy-wise, it's not been a plan for sort of another year, but those are sort of decisions that get made, so that can get made. So I think there's a lot of conversation about it, but it was done with a lot of other protections around not just sort of that expansion of coverage, but other dollars coming in and streams going in. So it is an issue, but it's not an issue sort of upon us right now because of the delay in the implementation of it, but I think it is one of those that are being continuously factored in. The health center funding is another approach that wasn't there, where individuals have been able to get medical homes and utilize that. But certainly it's an issue, and people are encouraging it to be delayed again because of exactly the reason that you said.
Question. Can you speak a little bit about the sequester? I know they're saying that in 2014 we're expecting to see more clinical cuts. Could you just discuss how, what cleaning services is expecting, how it might affect healthcare reform and public health overall?
Well, you know, it's a really great question. I don't have a crystal ball, but I'll tell you this. We have said from the very beginning that sequester is not the policy to put into place, that it's indiscriminate, that it hits programs that shouldn't be hit, population, and the like, and that there is a far better way to achieve balance in that. We continue to believe that. And every time, and this whole process of where Congress is now working on this conference committee because of the government shutdown and because of what we faced, the view has been you should replace the sequester with a balanced set of cuts, increases, and things that will save that. Now, we saw, and we were talking about it this morning, we saw when the government shut down, I've seen with the sequester levels what's that done to Indian health programs. I've seen what it has done to human services programs like Head Start. We saw what the shutdown did not only on Head Start, but to people who are using support services, meals, and other things that were cut from there. So real draconian effects. So the president has said that, you know, this notion of a grand bargain is one thing, but the notion also is of the sequester, you need to have some other way of balancing that. So, you know, I would hope that there's a way to move away from that because that's our real desire. Was there someone over here, did I see?
So we probably have time. The hardest part of my job is when it's the end of our hours. So I know people have class, but we probably have time for one more question,
Okay.
and we'll let people come up afterwards.
Okay, and let me point out for those that do have class, take the email and take the cell phone because I'm happy to be helpful to anybody and want to get you involved in whatever way, or if you're just looking for, you know, how did you get this awesome career? I'm happy to. I'm happy, seriously. And even though I work, I'll say it on camera, even though I work in San Francisco, I live in LA, so I'm here a lot. One of you has to have a question, I'm sure.
Okay, if they don't, I do.
Okay.
But I was
Dean's
talking about
prerogative.
that. So, you know, this is such a huge piece of work that you are doing and that so many people in this room have done it and people across the country we're thrilled about. Part of the reason you probably hear from the public health community, even though we are, you know, 100% and 1,000% behind the ACA, voices of concern, was the fact that the public health fund was deleted by the administration in order to get money. It was funds were taken out of it, raided, whatever term one wants to use, in an urgent need, a truly urgent need to get funds to get this off the ground. So for people who aren't aware, there is a public health fund in the ACA, but the administration, when it was unable to get other funding for getting this off the ground, took public health monies and took it away from public health training and other CDC and other public health initiatives and put it into the ACA. So my question is, when are we going to see that money again actually used for public health? Because many of us who are completely behind the ACA believe that the only way it will succeed is if indeed those public health interventions get off the ground so we can get ahead of diabetes, get ahead of heart disease, as opposed to being so far behind them right now.
Well, great question. I think what would be helpful to me in sort of saying how to sort of deal with that is to work with the community to prioritize what are those programs and what are those services, because I think there are a lot of things that are happening in public health that are not the big ticket items that are funded through the ACA, and so I understand sort of the loss of some funding, and obviously I've heard a lot from the public health community. So without saying, you know, do I know what the push is going to be? Do I know what the Congress is going to be? Do I know sort of how to do that? I think we understand the importance of it, and just sort of recognizing that, I would ask for the help in saying, okay, what are, in the best of all worlds, understood, restoration of $5 billion that was sort of shifted for somewhere else. But in the greater scheme of things, how do you prioritize those funds that are there? You know, LA County got one of the largest community transformation grants, you know, $10 billion, and what's that doing, and sort of how is that sort of working? So without making a prediction, but let me say one thing. What I've learned from sort of the partnerships that we've developed is that sometimes people go just to members of Congress and us when they want to talk about sort of public health and talk about ACA funding. But I always say, you know, every city council member, county supervisor, every other elected official, mayor, wants to be a member of Congress, and they have those relationships. So working together to try and promote what those are, because I can't honestly say, you know, is Congress going to, with the president or with the push, going to do that? I think I understand where you're going. But the only way I think for us to be able to help move the ball is to have an even greater sense of which those priorities are. I mean, I talk to the Prevention Institute and others all the time and say, help us prioritize what the ones that are there. Because you know, I get it. So I'm not sure that answered your question.
Thank you so much.
No, thank you. Thank you.